Okay, welcome everyone. My name is Haikel Nagash, and today I'll be hosting today's webinar by Dr. Amanuel Kehasse. Before he starts his presentation, I would like to give a short introduction about him. Dr. Kehasse earned his Bachelor of Pharmacy degree from University of Asmara College of Health Sciences in 2003 in Eritrea. Dr. Kehasse then joined the Orota School of Medicine and served as an assistant lecturer of biochemistry until 2005. At the same time, he served as the General Secretary of Eritrean Pharmaceutical Association, ERIPA. In 2012, he earned his Doctor of Philosophy degree in medical biochemistry from Boston University School of Medicine, Division of Graduate Medical Sciences. He then pursued his postdoctoral research fellowship at the Bach Institute, University of California, San Francisco, UCSF. His research focused on post-translational modification of proteins and biomarker discovery, and has published his research findings at American Journal of Pathology, Journal of Experimental Medicine, and Oncotarget. Dr. Kehasse became a registered pharmacist in the state of Massachusetts in 2015. He then pursued his pharmacy studies at Massachusetts College of Pharmacy and Health Sciences, which is MCPHS, and earned his Doctor of Pharmacy or PharmD degree in 2017. Currently, Dr. Kehasse is a clinical pharmacy specialist of rheumatology, dermatology, and interstitial lung disease at Boston Medical Center and adjunct assistant professor of pharmacy practice at University of Rhode Island School of Pharmacy. Dr. Kehasse heads the Professional Development Subcommittee of the Research, Documentation, and Professional Development Committee of Eritrean Pharmacist Connections, ERIPCO, and as part of this year's Professional Development Series, he will be presenting today's webinar titled Updates on Current and Emerging COVID-19 Prophylactic and Therapeutic Agents. I now pass the mic to Dr. Amanuel Kehasse. Thank you.
Oh, thank you, Heikel, and welcome everyone. I really appreciate that you take your time out of your busy schedule on a weekend to attend this discussion. By no means this is a discussion to me. It's not a lecture. It's not a seminar that I can give to everyone. I'm pretty sure that most of you probably have much more experience than me in this subject. So consider this is just an update on my part. And as much as I wanted to, I would like it to be more of a discussion than a lecture. So feel free to interrupt me in the meantime if you feel you have a question or some value to add. Like I said, I don't claim to be the expert on this field. I just happen to have some level of involvement in managing COVID patients in autoimmune diseases. So that is my limited experience. So I'm trying to do my best to give you the up-to-date information, probably the emerging information, because yesterday was different than today. Believe me or not, today I added a few slides to the slide deck because there's a lot of information coming in. So by no means, this is not the most up-to-date, but it's gonna be an introduction to discussion so that we can enrich it throughout the presentation. Heikel, are you able to advance the slides? Okay, I could do that. So as a disclosure, some of the medications or the vaccines that we are gonna discuss in this lecture are from Pfizer. And I have some financial relationship with Pfizer. I had received a couple of grants from them. And I'm also currently engaged in collaborative projects with Pfizer. But everything that I will say here will be pure scientific and clinical, and it will not be biased towards favoring their product over the others. So the objective of this discussion is going to be to provide a brief overview, because at this point, we all probably are in the same page when it comes to where we are in the pandemic status, but it will give us like an insight to the later discussion, probably in the therapeutic and the prophylaxis section. When we choose the therapeutic or the treatment agents, it would be a good idea to keep in mind where we are at the pandemic. And then we'll proceed into the outline of the current immunization guideline. This has changed significantly in the last 2-3 weeks. So we will update our knowledge based on the current guideline on the vaccine series or schedule. And we'll also evaluate and discuss the available COVID-19 prophylactic and therapeutic agents. And finally, for those of you who are residing in the United States, there is a new initiative called Test to Treat, by which pharmacists will be able to play a critical role in managing COVID positive patients. So I'll try to touch base on what it means for pharmacists in this new initiative and how can we contribute better, both for the profession and the patient population that we serve. So this is one slide summary for where we stand with respect to the infection rate and the death rates throughout the globe. The most important thing that I want to draw here is the lower left and right graphs. So you can see in probably December of 2021, we hit the peak new cases where we had the maximal infection rates. Now we are in a better situation, but still, as you can tell, this data is last accessed on September 10. Our baseline is not back to zero. Our baseline is into like a couple of hundreds of thousands of new infections. And also I wanted to take this one with some grain of salt, because back then we didn't have much of the home test ability that we are currently doing. But currently, a lot of people are testing at home with these fast, like rapid tests, and not necessarily reporting their positive tests to the health authorities to be counted. So I think this number is still high as a baseline, but it will be much higher if we count the home test results as well. But what is comforting is the death rate is actually much lower than we were at the high and close to baseline. This is a testament to, one, the efficacy of the vaccines that we currently have, and two, the therapeutic options that we have, including the prophylactic that we use. And third, by now, almost everyone either is vaccinated or have been tested positive for COVID. I'm talking again about the European and the United States section. Other regions of the world probably have different story, but in the United States and the Europe, probably either you're vaccinated or you somehow have got the infection already that will generate some level of protective antibodies to begin with. So we don't see much of hospitalization and deaths at this point. What is more important at this point is, I'm sure everyone is aware of the COVID variants. The virus, like any other virus, keeps mutating. It changes its behavior. And the more it mutates, there's a chance that it can evade the vaccines that we have or the therapeutic options that we have sometimes. So in the United States, there is a surveillance of genome surveillance protocol. So at this point, I just want to draw your attention to the right side at the bottom. You see the blue section is BA4.6. This is the new variant that is currently circulating in the United States. It's about 10 to 15% circulation. And it's particularly important variant because there is a chance that this variant may evade the vaccines that we have available and the prophylactic agents that we have. And I will discuss those details in the later slides. Now let's switch gear with that brief introduction into the COVID prevention and therapeutic options we have. And this is an area where pharmacists probably will have a bigger impact. One, with available vaccines, now pharmacists are allowed to vaccinate. And two, to provide the prophylactic information and the medication itself to our patient population. Here in the United States, pharmacists are considered the most accessible healthcare providers compared to other healthcare providers. So equipping and engaging the pharmacists in this initiative really will help, especially addressing the needs of the underserved community or communities that doesn't usually get the healthcare service as easy as the well-to-do communities. So the vaccines that are currently available under FDA approval or emergency use authorization are these three groups. We have two of the mRNA vaccines. One is the Pfizer-BioNTech, marketed as Comirnaty. And we have the Moderna or the Spikevax ones. And both of these ones have the monovalent and the bivalent versions of these mRNA vaccines available right now. And we have the protein subunit vaccine, which is new to the market, the Novavax. And we have the vector-based vaccine, which is J&J. Currently not much used, but it's been used quite like significantly in the early age because in the early days because that is produced similar to the old vaccines that we have, and people had somehow a little more trust in the old technology than the mRNA technology. So some people prefer to take the J&J, and at this point, probably we have a significant number of our population vaccinated with the J&J as well. As pharmacists, what I want us to know and educate our patients is that these vaccines they do not contain any preservatives. They don't have any antibiotic in them. They did not come from a tissue because there's a lot of misinformation going on that the cell line that these vaccines were tried initially came from embryonic cell line, but that doesn't mean these vaccines are made of any tissue. It was the initial, like years ago, the initial test of the mRNA technology was tested on those cell lines. And as pharmacists, we can equip our patients like these vaccines actually do not contain any preservatives, no metal, no mercury. And again, there is no cross reaction with any food or protein allergy that they may have. So prior to having the bivalent vaccine, the vaccination schedule was really, really complicated, and especially with a special population group, for example, immunocompromised or immunosuppressive patients. We were up to dose number 5 in certain section of the patients. Most people would be 1 booster or 2 booster, but some patients were actually eligible for vaccine number 5, which we call it booster number 3. But now that we have the bivalent vaccine, that schedule has significantly been made easy. So if you take a look at the younger age group, which is 6 months to 4 years old, for the Moderna vaccine, you are looking into the 2-dose series vaccine, and both administered probably within 48 weeks. And as a general principle, the 4-week was the initial guideline given, but with some research and data came out of some research, the more you delay it, the more you give your body to actually generate enough response from the first vaccine, the better boost you will get from the second vaccine. So extending it towards the 8 weeks and even longer, if you can afford that, would be advisable in SWAT. And this applies for all the vaccines that we have. For the Pfizer-BioNTech, this dose series for this age group is a 3-dose series. First one will be within 3 to 8 weeks, and then 8 weeks later, after the second one, you can administer the 3rd primary series. For the age group of 5 to 11, and again, you're looking into 2-dose series for the Moderna and 2-dose series of the primary for the Pfizer, plus 1 monovalent booster. So unlike the other age group, which is 12 and above, any booster at this time will be only the bivalent. You cannot do the monovalent booster at this time, except for this age group, and that's getting the Pfizer vaccine. When you have the relatively older or teenage and above age group, both the Moderna, Novavax, and Pfizer have the same schedule. You have the 2-dose series for the primary series, and the booster would be one of the either Moderna or the Pfizer bivalent vaccine. And this vaccine is also indicated at least 2 months after the second dose. If you have someone who has 3 or 4 doses already, that also counts. Like you have to administer this one at least 2 months after the last dose that they have. The minimum requirement is that this patient have to get at least 2 vaccines to begin with to qualify for the booster. And again, the 2 months is the minimum requirement. It doesn't necessarily have to be at 2 months. I've seen a lot of communication in the medical world here. Like patients are like, I waited 2 months so I can get it right now. I generally advise them, if they're not at high risk of disease complication, to wait a little longer, about 4 or 5 months to get the booster, because at that point we have enough data to justify that you will have a better response to the vaccine as opposed to just getting it close with each other. If you have someone who has previously gotten the J&J vaccine, and at least 2 months later, you can give them the booster, the bivalent booster. I don't think anyone is getting the J&J at this time, at least in the United States. So the 2 months probably will not have any meaning at this point, because it's been more than a year since we stopped using the J&J. unless there is a specific request. But the dynamics is a little different when it comes to the immunosuppressed or immunocompromised patient population we have. And primarily this is, not primarily, but most likely this is because their immune system is not as powerful as the general population. And it needs a little more tweaking or maybe a little more wake-up calls for it to generate enough protective antibody titer to prevent them from disease complication. So for the Moderna, you're looking into 3 primary series, as opposed to the first one. For the first age group, we had 2 primary series. When it comes to the immunocompromised or suppressed patients, you have to give them 3 primary series for both the Moderna and the Pfizer-BioNTech. For the 5 years to 11 years old, again, you have 3 primary series of the Moderna, but the Pfizer-BioNTech, they will get 1 additional monovalent booster. The bivalent booster, again, is not indicated for anyone younger than 12 years old. If you have the older population or teenage and older, 12 and above, and you have to have in both Moderna and Pfizer 3-dose series first before you get the bivalent booster. For Novavax, there is no 3rd dose for the primary series. It's only 2 primary series. So the 3rd dose will be your booster. And if you have someone who had the J&J vaccine, and then you have to give them one of the mRNA vaccines before you give them the booster. So primary series is the J&J, and additional primary series would be one of the mRNA vaccines, either Pfizer or the Moderna, and then you can give them the booster at least 2 months after the 2nd dose. And there's also a question that I want to highlight here. What if you want to mix and match the vaccines that we have available? There is data now to suggest, not to suggest, but to prove, at least for the mRNA vaccines, if you give the first dose of the mRNA vaccine with Pfizer and you give them with the Moderna for the 2nd or the 3rd series, patients tend to develop a much higher titer of antibody against the COVID virus. And the same is true if you give them Pfizer, if you give them the 2nd one with Moderna, that is also applicable. So at this point, especially if you have immunocompromised or immunosuppressed patients, I usually mix and match these 2 mRNA vaccines for my patients. And the same will hold true for the booster, even though the booster dose have a little different content of the ancestral and the current variant, but the principle remains the same. And also there is some data from Brazil and Spanish that they mix and match the mRNA vaccine with the protein-based vaccine as well. And they observe a similar boost. If you mix 2 different vaccines, and that you will get a little higher boost. And this is primarily because instead of just waking up the already primed T and B memory cells, at that point, what you're trying to do is you are trying to prime the germinal cells that are not woken up yet. So you can increase actually new lines of T and B cells to get into the memory cell line reserves. So the bivalent, I think my transition is a little faster because I want to address much more content within a shorter period of time. So currently, there is a lot of discussion going on about the bivalent vaccine that we have. And most of the discussion is going around what is the principle of the bivalent or multiple valent vaccine versus what is the evidence supporting that one. So in principle, if you have a vaccine that's closely related to the currently circulating viral strain, you will have a better response to that in protecting any disease complication as a result of that circulating variant. However, if you have mRNA that closely resembles to the ancestral or the original virus, which has already currently evolved into a much different protein spike structure, you may have a lesser response to begin with. So in principle, this is well supported, and it has been done so far. At least the closest example I can mention is the flu vaccine. Every year we scan or we survey the current variants of the flu viruses that are circulating in the southern hemisphere, and they try to develop a vaccine that matches that circulating variant, and it works for the most part. When you miss that one, then that's when you have or the pandemic or epidemic or a high rate of infection in the community. But that is not only a principle. We have at this point some data to support that notion. This is recently published data in Journal of New England Medical Journal, and this is primarily looking into the mRNA variant targeting the BA1. Remember, this is not the BA4 and 5 that we have currently circulating in like the most dominant one. This is the earlier variant that we have, the beta version. So this mRNA vaccine was targeting that variant. So if you take a look at its efficacy against the Omicron, which is the B1 variant. I'm sorry, I just misspoke. It's not the beta variant. The B1 is the first lineage of the variant from the Omicron variant. So the Omicron have subclasses. So this is the earlier one. So if you take a look at the neutralizing antibody titers, and this is not this is human beings getting this vaccine, but the analysis was done after blood was drawn from these patients and tested in a petri dish, their neutralizing ability against this virus. So if you have the yellow, I'm not sure if you see the yellow in your end, is the yellow graph shows us the mRNA, which is the bivalent mRNA. Which half of it will be the ancestral, the original virus, and half of it will be the BA1 mRNA. So before and after boosting, 29 days after boosting, you have a significant improvement in generating neutralizing antibody against Omicron BA1 variant. If you do vaccinate or boost these patients with the original vaccine that we had, you still see significant amount of boost against the Omicron, but it is comparatively smaller amount of neutralizing antibody compared to the bivalent. So this is one justification, like the more closely resemble mRNA vaccine design you have to the current circulating variant, you have a more titer that you will produce a new antibody. Again, the question is, does antibody titer always translate into clinical efficacy? Yes, it does, but not 100% of the time. We'll discuss that one later. If you take a look at the right side of this slide, we have neutralizing antibody titers against the ancestral. Okay, this is the first one is against Omicron. How about the bivalent? Does it actually work against the original virus? Yes, it does. It actually is non-inferior with the original vaccine. So technically, you would expect the mRNA 1273, which is the ancestral, designed against the ancestral, will have a better response. But at this point, you see the data it mirrors itself. So it's non-inferior. So the advantage, you have a better response against the currently circulating variant, but also you have equal response to the ancestral variant as well. How about for patients who have not had any previous infections? And the same principle applies here. You see against Omicron on the left side and ancestral in the middle side. In both cases, both the ancestral, the original vaccine booster and the new bivalent vaccine generate significantly greater amounts of antibody titers in both situations. And when it comes to the side effect profile, always when you're given medication, you have to think about the benefit versus risk. And the risk is primarily the side effects. The local reactions, I usually call them expected effects. They're not side effects, because you are trying to prime your immune system to generate antibody, and inflammation is part of that process. So if the patient have a little more inflammation, which will be manifested as pain, arthralgia, or maybe fever, that is what you expect this patient to feel. So that is expected effect. And in both cases, you have almost similar. The systemic reactions are a little more concerning, but in this case, also there is no significant difference in both. When we talk about the systemic side effect, we probably are talking about the myocarditis, pericarditis, and other blood clots side effect, which I will discuss in later. To begin with, that is not significantly higher, especially compared to the side effects, similar side effect you may experience as a result of COVID infection. But to add a little more data, this is the most recent data we have, and we have actually now the advantage of actually seeing different version of mRNA vaccines. So we have now here, and this is a mice data, not human data. So we have the original mRNA booster, which is against the ancestral 1273. And we also have the 1273.214, which is against the BA1. That's the vaccine that we discussed in the previous slides. And we also have the vaccine series that contains the 1273.222, which is the currently released bivalent vaccine against Omicron BA4 and 5. So I want to draw your attention towards the end where you have the BA5. And then the left side, we're looking into the original, the Wuhan version of the virus, that level of efficacy. You can tell whether you give a patient, or not a patient, the mice, the original the vaccine, or the BA1 variant against the BA1 variant, or against the BA5 variant, you almost have similar antibody titer. And that actually supports the result we've seen here. So not only against the BA1, the current vaccine also have similar antibody response against the ancestral. And we have the BA1.6, BA1, and BA1.5. And across the board, you see the same response. And especially, I want to draw your attention to the BA5. The third graph is if you give this patient with, I'm sorry, if you give the patient with either against the original ancestor virus, BA1 variant, and the BA5, you see significant increase of improved serologic titer the antibody. So this also supports that, serologically speaking, giving the bivalent would be more advantageous for your patients as opposed to giving your patients the original serum against the original virus. For two reasons. One, it gives you optimal antibody titer against the current circulation variant. Two, it will also cover you for the original virus. So what are the considerations that we have to take into account when we are vaccinating or recommending our vaccination to our patients? I think for the most part, these vaccines have demonstrated to be really, really safe and effective. There's no question about it, at least in my mind. But there are certain things that we cannot ignore as well. There were some myocarditis and pericarditis that was observed in young male, and this is specific to this general population. Young male, be it healthy or with any underlying cardiovascular disease, there was some signal that pericarditis and myocarditis can happen. But always, what is your reference? How about if you do not vaccinate this person and you let them get infected with the COVID virus? If the COVID vaccine can give you about 12.6 cases per million of this incidence, COVID infection will give you 450 cases per million. This is significantly higher compared to the compared to the vaccine. So by no means, I would not hold this vaccine for someone who is at a young age out of fear of this one. If they have pericarditis or myocarditis to begin with, and that's a different story. That you have to take some precaution before you give them, or maybe a close monitoring. The other signals that were observed was the vaccine-induced immune thromboembolic thrombocytopenia. And this is, again, one case in about 100,000 people. And this is mostly related with the adenovirus vaccines. The pericarditis and myocarditis were mostly observed not mostly, exclusively observed in the mRNA vaccines. And the blood clot was also another that was on the topic of discussion for quite a while. But if you compare with the blood clot risks, when you get it out of the infection compared to the vaccine, you have about 12,600 of this incidence if you have about 10 million people infected with COVID. However, the vaccine-induced incidents are only 6 in excess in 10 million. So numeric-wise, this is not really significant, but this discussion probably will have some value. How many booster can you give someone? Because the cumulative effect of this insults to the pericardium or the blood clot will probably have some significant effects down the road. So this discussion probably will be more meaningful in the number of boosters that you can give for these young adults, and keeping in mind that this patient population doesn't have really significant risk of hospitalization and deaths out of COVID. The other consideration that we want to have to take into consideration are the disease states that the patients have. Do they have an autoimmune disease? Or do they have any transplant? It could be kidney transplant, liver transplant, any transplant, because these patients will be severely immunosuppressed because of the risk of organ reject. So you have to take these patients as a different population. One of the challenges that we have in the early days of this vaccine rollout was there wasn't actually a clear guidance that will address this patient population. All the guideline was for the general population, and these patients were, for the most part, probably ignored. Give me a second. I think someone is trying to get in. I'm going to admit it. Okay. So those population has to be addressed a little differently than the general population. Now that the vaccine series has tried to address it, but not only that, with the dose itself, I can go back into the vaccine series. Moderna, for example, the booster was half a dose of the original dose. But when it comes to these patients, you cannot rely on a half a dose of Moderna because they do not respond quickly to the vaccines to begin with because they are immunosuppressive. So in our clinic, we give them the full dose regardless. We follow the guideline, but as a clinician, you have an option also to amend the guideline. Guideline is not a time, it doesn't have to tie your hands. You have to always consider the risk and benefit for your patient population. So you can have some flexibility there. In the current medication list, this was really actually, at least in the patient population that we care, I practice in an autoimmune disease heavy patient population, and some of them have an overlapping oncology indication as well. And they are in a severe immunosuppressive medications like the B cell depleting agents. These are in my mind, these are the top immunosuppressive medications. What they do is they eliminate your B cell from the circulation at all. If you take this medication for about 6 to 8 months, you do not have any circulating B cells. And as we know, our immune system generates the antibody from the plasma cells that are mature B cells. If you remember the biochemistry of our immune system, you have the T cell activation, complement activation, and B cell activation. B cells will then develop the antibodies. If you do not have the B cell to begin with, how are you expected to generate the antibody that you are supposed to out of the vaccine? Of course, there is some value of the T cell activation, even though you don't have B cells. T cell activation tends to be a non-specific defense mechanism. There is some value, but patients will think that I'm vaccinated now, I am good, and they will expose themselves only to find out they don't have any fair chance of fighting against the infection. So rituximab, ocrelizumab, and obinutuzumab are the 3 medications that I dealt with the most. And we had actually data to demonstrate that if someone on rituximab got the vaccine, when we test the antibody titer, definitely 0 level antibody detected. And the same was, not same, but similar trend was observed in the T cell activation modulation. Primarily, Abatacept is one of the T cell modulators that we use, and mycophenolate, which is a broad T cell modulator. And patients on these medications tend to have at least 50 to 35 to 50% reduction in their antibody titer generation. And you have to treat these patients differently as well. So this is my famous workflow. I try to make this one as simple as possible. This is the simplest I can make. Once we were faced with a lot of challenges that our patients on these therapies that I was mentioning earlier were getting the vaccine regardless. And they were thinking they're protected. And there was no guideline to guide us to do anything different for this patient population except some expert opinions telling us, okay, they might get some benefit out of the T cell activation, but B cells, just give it up. You're not gonna get anything. But patients didn't have that mindset, like, I need to get this vaccine, I need to get protected. And the moment you vaccinate them, they think that I'm okay now, and they will lower their guard. So at least in our institution, in other vaccination sites we don't have any control over, in our institution, what we did was we put this as in each room that we have vaccinators. We posted this one. We asked the vaccinator to ask this patient, do you have any of this medication in your medication list? If so, then they will have to page us so that we can assess. So what it tells us is the left part is addressing the patient that we already missed it. They already got the vaccine. So we can't do anything at this point, but we check their antibody titer and see if they have any detectable or not. And on the right side is for those that are not vaccinated, we try to see if their B cells are populating back. That's the right time for them to get the vaccine. So we hold the rituximab infusion or the therapy for quite a while, or switch them into other treatment options and wait for the B cells to come back. And that's the right time to vaccinate them. Before CDC actually authorizes the booster dose and the third dose for patients immunocompromised, Boston Medical Center actually, we used this one and we had some evidence to support our initiative. We actually diverted from the CDC guideline and we started actually giving a third dose for patients on abatacept T-cell modulators, a third dose mandatory. And for those who have been vaccinated while on the B-cell depleting therapies, we scrap out all the vaccine history from there, not scrap out, but just redeactivate the vaccine history. And we revaccinated these patients all over after we made sure their B-cell therapies are, their B-cells are repopulated. So this is really, really, to say, I'm just trying to highlight here, not everyone will respond the same to the same guideline. So as clinicians, as pharmacists, we have to equip ourselves and we have to engage our patients to check what medication they are on before we even give them the vaccine and advise them the right time for the vaccination, because giving the vaccine is not going to necessarily protect them. Giving the vaccine at the right time probably will do much of a difference. So what does our COVID vaccine coverage look like? Certainly the green part is the most vaccinated area. And this is a little misleading actually. The green is greater or equal to 100 per 100 person population. This is not a completed vaccine series. This is number of vaccines. So for example, if you have 50% of the population get 2 doses, you will have the green highlights. But what is I wanted to draw my attention is in certain part of the world, especially Africa, you see it is even not close to the optimal coverage for the first dose. It's very low. And in the green area, there is a lot of vaccine holdups as well. Not everyone is taking it as recommended. And part of the reason is there is some disparities, inherent disparities. Some part of the population has been neglected for quite a lot of time, and now they lost trust of the health system. So they needed to be educated, re-educated, and probably empowered and build trust with the healthcare system for them to adopt these recommendations. And one of the common hesitation that we heard was, this vaccine just came into the market within 1 year. How come? There are a lot of other vaccines that it took like years to get into the market. But this is different. We are in a pandemic situation. First of all, I don't have to tell you this one because all of you probably know all the reasons behind why it was fast. But it just suffices to mention that the technology was on the way to begin with. And there was a lot of collaboration happening between government and non-governmental organizations and industries themselves. They were sharing information as they know new things. So all this combined, and FDA had given them like a little more relaxed regulatory hurdles so that they can actually advance to this phase 2, phase 3 clinical trials, as long as they have some level of data, convincing data this medication or this molecule that they're trying has actually positive results, as long as they can demonstrate some preliminary data suggesting it will hit the primary and secondary endpoints. They will allow them to have a secondary or the next phase of trial while continuing the previous trials as well. So, and the money was not an issue. Government actually allocated a lot of money for this one. So industries were not risking any financial loss by doing all these multiple steps at the same time. But the other common reason is, and this is really pervasive, and it actually hit a lot of, not only the general population, but the medical community as well. There was a lot of misinformation from scientists or clinicians. At this point, social media probably will get you a little more salary than your average job. So there are some clinicians and scientists that are engaged in social media, public education realm, and throwing anything and everything they can get their hands on, anything and everything that can attract public following in their sorry. So this one, I just got this one yesterday, and this is a recent publication from October 4. As of May 5, 2022, there was 138 COVID-19 related publications that are retracted. So retraction, as you all know, means that the publication didn't actually meet the standards, or after it was published, it was found out either the results are not accurate or the conclusions are not accurate. So out of the 300, you had 380 non-COVID retractions in this time period. 138 is really, really significant. Like, this is one disease versus all other disease states or other publications. This is not something that we should take comfort to. It is okay to publish data as you get it, so that you can share with colleagues, so that they can make use of it, because we're in a pandemic. But the science through, I call it press release, has to stop at this point, because this is what you get. You have to have peer-reviewed publications distributed to the public, because the public doesn't necessarily have the ability to sift through all this information and get the right information. I don't mind this one circulated exclusively for the medical community or the scientific community, because they have some level of sifting ability. But for the general public, it probably will have more harm than benefit. And I bring this publication. This is my favorite publication of on the COVID, and this was probably one of the initial publications that claimed that hydroxychloroquine with azithromycin actually have a positive outcome for COVID therapeutics. The publication that, or the publicity that this hydroxychloroquine received is beyond my imagination with the level of evidence that we had on hand. But more than that, it also affected quite a significant amount of our patient population. I'll explain that one later. Hydroxychloroquine is the first line therapy for patients with lupus. And in our clinic, we have about 400 lupus patients. The moment this medication was publicized, it was on short order. We couldn't even order it for our patients. And multiply that with other clinics that they have lupus patients. It was a real struggle to get hydroxychloroquine for this patient population. So forget the patients who are getting it for the COVID itself are not getting any benefit for sure, but it also significantly affected the other population indirectly. And that was really quite few weeks that we had to go through. A practical example, I borrowed few students from our hospital. So what we were doing every day was calling CVS, Walgreens, Walmart, any pharmacy. We mapped our patient population by zip code. And every morning we tried to map these pharmacies who have hydroxychloroquine in stock, so that we can direct our patients, hey, this pharmacy have this hydroxychloroquine, go and get your medication there. Or sometimes there were instances that I have these prescriptions delivered to my office, and I have my patients come to my office, pick their medication. So it significantly affected us. But what is the proof that it doesn't work? First of all, the clinical trial design, it's not a clinical trial, actually, it's a pilot study at best. It enrolled 42 patients. 6 patients on the hydroxychloroquine group actually went into ICU. And these patients were not included in the final analysis. So this is a selection bias in your analysis. This is a textbook example of a bias in your research. And azithromycin with hydroxychloroquine you are actually significantly increasing the QT prolongation, especially if you have patients with underlying cardiovascular problems. This is a recipe for patient damage. But what do we know extra? There was like randomizing clinical trial, which is one of the gold standards of the studies. And we have actually meta-analysis of studies, of other studies. And they all demonstrated hydroxychloroquine does not actually have antiviral property, and or it doesn't reduce the disease burden or hospitalization or deaths in these patients. So, but that's the world that we live. So just keep in mind, whatever is published, it doesn't necessarily mean it has significant clinical value. The other publication I want to mention is ivermectin. There is a lot of discussion going on ivermectin. Ivermectin is still in the discussion. There are quite a number of scientists that still claim ivermectin could be used for COVID therapy. But to me, the discussion is lost in the weeds, because all we know is some physicians will tell you, oh, we use this ivermectin for our patient population, and we have seen a significant decrease in mortality rate, or patients recovered quicker. I believe you. You may have that data, but what population are you talking about? If you are claiming that ivermectin has an antiviral property, no, there was clinical trials or studies that demonstrated that ivermectin does not have any antiviral property in human beings. There is an in vitro studies that suggested that one, but in clinical trials, ivermectin does not have any antiviral property. However, if you have patient population that lives in an endemic area for parasitic infections like strongyloidosis, for example, if you have COVID and complicated COVID, your immune system will be weakened. And some of these parasitic infections can actually become an opportunistic infection, and they can actually add a burden to the disease and accelerate the death rate or disease complication. And this study looked into this notion actually. So they took a look, okay, what is the value of ivermectin in patients who reside in areas where they have about 8% and above endemic area, and other studies with lower risk of this parasitic infection, less than 8. And the trend is clear. In that area where you have high rate of these parasitic infections, the results, and the result here is not antiviral property, it is death rate or disease complication. You see the data, the meta-analysis data skewed towards the left, which favors ivermectin. So patients who are taking ivermectin in this highly endemic area, surely they did better than those who didn't take that one. So there is some value to that. But in those low endemic area, you can see all the statistical analysis done was just on the mark. So there is no value to that. So this could be beneficial if you have someone with those strongyloidosis or other parasitic infection that ivermectin is indicated for, to have it as add-on therapy on that population. And quite frankly, a lot of hospitals in the United States actually use that ivermectin if they have a patient who came from those endemic area and there is a positive result of that ivermectin infection at one point. So in that case, there is some positive value, but as an antiviral infection prevention, it doesn't have any value. But all the discussion you hear is ivermectin is good for COVID, ivermectin is not good for COVID. You have to be able to dissect all the information that you have. On the right part, we're looking into the graph or the all-cause mortality regression rate, the value of ivermectin. For there is almost 38% risk reduction in deaths for every 5% increase in that prevalence. So all these studies, and I say, just follow my previous slide, the retracted number of studies. I'm not saying this is the perfect study, but there is some indication that warrants us looking into this one in a more detail than just simply dismissing the whole value. All right, now let's switch gears into the COVID-19 therapeutic options. We actually have either approved by FDA or granted an emergency use authorization. We have antivirals, remdesivir, mainly used in an inpatient setting. And we have the Paxlovid and molnupiravir, which are antiviral oral therapies that are available for both, not both, for outpatient setting only. We also have the monoclonal antibodies. Bebtelovimab is one of the post-infection COVID therapeutics options we have now. And Evusheld is our prophylactic monoclonal antibody that we have currently. And we also have some immunomodulatory or immunosuppressive agents that are used primarily in an inpatient section, primarily, again, not against COVID, but to counter the risk of cytokine storm syndrome. So what is the evidence for remdesivir? I just put this slide. There are a lot of other studies for remdesivir that probably showed a little different data than this one. But this is just all to say this has a limited applicability for inpatient, highly severe disease conditions. For the general population, the left part of this graph, it is overall patients. You see minimal difference. If you see on the middle graph, for people who are not receiving, like severely ill, but not receiving oxygen supplement, there is some difference, but the most difference you see out of remdesivir is for patients who are actually receiving oxygen supplement. At this point, their lung gave up on handling all the breathing ability, and you're supplementing with oxygen. So this is mainly reserved for inpatient admitted or ICU section for patients who are either mechanically or supplemental oxygen required. The second oral medication is Paxlovid. This is a combination of two antiviral medications. Nirmatrelvir is a protease inhibitor, and this medication is a combination with ritonavir. Ritonavir, probably we all know, it's one of the therapeutic agents we use for COVID, for HIV infection. On its own, it's a protease inhibitor, but in this case, and as well as in the COVID, in the HIV treatment, it's not used as an agent, but it's a pharmacokinetic booster. What it does is it just inhibits the cytochrome P450 so that you have a higher bioavailability of your protease inhibitors circulating. So this EPIC-HR is a phase 3 trial, double-blind, randomized controlled trial. And what we see here is patients treated with Paxlovid and treatment initiated within the first 3 or 5 days tend to do well. And the end goal, or the primary endpoint of this trial was hospitalization or disease complication or death. So you see a significantly low number of patients on Paxlovid maintaining their minimum or minimal infection symptoms. However, the placebo-treated patients have a higher rate of hospitalization and death. But if you tell at the bottom part of the middle part of the graph is blown up, the significant difference is not that much. And this is because Paxlovid does not have the same protective effect or the same margin of effect for all populations. You have to always see and choose which patient population will be beneficial. As a general trend, we do not have many of the young, healthy people getting admitted into the hospital or dying out of COVID. People who are either on immunocompromised patients or either have any of the risk factor for disease complication will be at a higher risk of getting hospitalized and maybe death. So this medication, if you do the subclass analysis of the studies, patients of 65 years old and above actually get the most benefit out of this. And patients with one or more risk factors to disease complication got actually more benefit out of this. So when you engage in your patients, healthy patient, probably they will not have significant, there will always be benefit, but it's probably is not going to be a significant benefit out of it. As a result, the indication is limited to patients. One, you have to have moderate to severe disease. You have to have COVID in diagnosis. You cannot use this one as a prophylaxis. Positive result is required to start this therapy. And you have to have high risk of progression to COVID-19 disease progression if you have diabetes, body mass index of 30 and above, or cancer medications, any of these high risk disease states, cardiovascular disease, hypertension, all the diseases that will predispose you for disease complication, that will qualify you. The dosing is a combination of 3 tablets for 5 days. It will be 2 tablets of the nirmatrelvir with 1 tablet of ritonavir as a pharmacokinetic booster for 5 days. And there is also a good amount of renal involvement in clearing this medication. So if you have a patient with severely renal compromise, this medication probably is not the right medication because you will have more of the metabolized accumulation and side effect profile. And if you have less than 30 GFR, then at all, this is not indicated for the patients. If you have someone between 30 and 60, and you have to reduce the dose, instead of giving them 300 milligrams of nirmatrelvir, you have to give them 150 of nirmatrelvir with 100 milligrams of ritonavir. So technically, you're giving them half of the dose. And the most common side effect we see out of this medication is dysphagia or maybe diarrhea and myalgia, well-tolerated medication. So other consideration for Paxlovid treatment is the treatment criteria. So as all antiviral therapies, not all, some antiviral therapies, including flu, the best time to start therapy is within the first 2, 3, or 5 days. Those are the days that you will have the maximal effect of the treatment. So if you have someone from initial symptoms onset within the first 5 days, Paxlovid probably will be a good idea to start. If they have more than 5 days since initial treatment, initial symptom, not the test date, the initial symptom onset, then Paxlovid probably would not be a best idea to start them. Renal function, I briefly discussed it. The hepatic function, and primarily here, those who have Child-Pugh score of B or C, which is more of the advanced cirrhosis level. And this medication probably would not be a good idea to try because it's heavily metabolized by the liver. So for someone with Child-Pugh score of B and C, you cannot start this therapy. So drug interaction, Paxlovid, actually, this is funny because how many of you remember the American Medical Association actually petitioned CDC and FDA to prevent pharmacists from prescribing this medication? And one and only reason they provided is, oh, this medication have a 6-page long of drug-drug interaction. So pharmacists are not the right person to prescribe. Actually, that is the reason you have to have a pharmacist to address this one. But that has a lot of different reasons why they try to petition now and then, because pharmacy profession is trying to get the provider status recognition federally, and having this small chance of intervention or prescriptive authority will get us closer to getting the federal recognition, medical recognition as provider. And that is what they have in mind. If we allow them to have like this small increasing level of intervention as clinicians, and one day they will probably have the provider level, and that's probably the intention. But again, it comes back to our discussion of a lot of drug interaction. The list of drug is huge. You cannot remember them. So you have to have a resource. You constantly have to get and check the drug interaction. But how do you make a decision? Not all drug interactions are the same, right? So in my practice, what I do is, if it is a drug that is, for example, amiodarone for cardiovascular indications, I cannot hold this medication for 5 days without consulting the cardiologist. And getting hold of the cardiologist within the first 3 days that I wanted to start therapy for this patient is slim to none, because you all know the communication in the medical field, it sometimes takes at the minimum 72 hours. You don't have all those luxuries. So if I have someone with a medication that I'm not comfortable to hold or to reduce the dose, psychotherapy medications, for example, a medication that probably will have a more higher risk of that disease complication compared to the Paxlovid therapeutic options outcome that I'm looking for, I probably will not start these patients on Paxlovid. Instead, I will go for the monoclonal antibody, which tends to have almost no drug-drug interaction. If there are minor drug-drug interactions, for example, amlodipine, blood pressure control, most of our patients have their blood pressure cuffs at home. I would advise them, cut your amlodipine in half and then just monitor your blood pressure every day. If you have any blood pressure lowering, just let us know so we can adjust your medication. So you always have to just take a calculated risk how you want to adjust doses of the other medication, or if you want to hold them. One particular thing that we kept missing, or I've observed people missing, is the effect of this one on birth controls. So Paxlovid will significantly decrease the efficacy of birth controls, and people tend to ignore that birth control is actually one of the crucial medications. And patients will take Paxlovid when they are on birth control, thinking they are safe, and lo and behold, they will have conception happening. So always just ask, even though it's not in your pharmacy medication list, ask what other medications do you take. Just try to be as exhaustive as possible so you can avoid all these untoward effects. And it's not indicated for pregnant women and breastfeeding because there's no study to suggest for its safety or efficacy. And I mean, not efficacy, but for its safety profile in pregnant and breastfeeding women. And another hot topic of discussion is Paxlovid rebound. I call it COVID rebound. I don't call it Paxlovid rebound. And mainly because it is not due to Paxlovid that you're having the rebound. It is the nature of the virus. We have always a recurrence of infection. That's why we have the word recurrence in medical term. A patient have recurrent infection of UTI. A patient have recurrent infection of ABCD. We always say that. And COVID is not different. It just so happens that because patients who are being treated with COVID, with Paxlovid for COVID, we're getting reinfected or relapse is happening. Oh, I thought I was safe. I thought I was treated. Why is this happening? And immediately the name was tagged with Paxlovid rebound. It is not. And there was some study to see actually if there is any resistance to Paxlovid that is resulting to this rebound. No, it is not. And there also was a theory that maybe it is a bioavailability of the Paxlovid. That was plausible, but there's no evidence to support that the Paxlovid bioavailability is linked with the Paxlovid rebound. It's just like your fair chance of having the recurrence of infection. What has happened? We don't know, but there are certain theories, including the one that I mentioned earlier, that claim probably there is a resistance, or maybe there's a bioavailability issue, or maybe there is no complete clearance, which seems to be more plausible to me. And why does it happen? I mean, to who does it happen? Mostly we see this one, I cannot say mostly. Most of the people that I know that happened Paxlovid or COVID rebound are advanced age with comorbidities that have minimum resistance to the COVID to begin with. So if you have not clear, insufficient clearance of the virus can revive and attack you again. Or it could be a reinfection as well. Unlike other infections, for example, if it's a hepatitis C, I can test you and see if this is a reinfection or rebound, because we have different genotypes that we can easily test. Here, we're not there yet, but at one point we can actually test, and if it's the same variant of infection that you have, or if it's the same variant of infection that is recurring. But it is on the discussion field, and just make sure that you update yourself. Eventually, it will come back as a question by your patients or any provider who is consulting you. The good thing is this COVID rebound or Paxlovid rebound doesn't seem to require additional treatment. I've had probably 5 or 6 patients of mine that I treated with Paxlovid had this rebound, and within a week or so, they already had and imagine these are immunocompromised and suppressed patients. They had a minor disease manifestation to begin with, and it was cleared within a week. So the agreement, I mean, the understanding or the consensus is it does not require additional treatment unless the patient progresses into severe disease complication, which at that point you will have to use the monoclonal antibodies. The second oral antiviral we have, not really exciting as far as I'm concerned, is the molnupiravir. And primarily this is, everything's comparative. Like if I don't have any other medications, molnupiravir is a good option to use because something is better than nothing. But the clinical efficacy here, the Paxlovid, we're looking at more than 90% of reduction in disease complication and hospitalization. Molnupiravir, you're looking at 30% at best. So when you have Paxlovid that is highly efficient, and when you have the monoclonal antibody that are 90% and above risk reduction, why would you go for this one? The only reason I go for this one is if I cannot get access for Paxlovid for my patient, or if I cannot get access for the monoclonal antibody at that point, or if I have someone who have significant drug-drug interaction of multiple agents that I cannot objectively either hold medications or reduce doses. At that point, molnupiravir is a good option because it does not have much of a drug-drug interaction profile. Again, the indication, similar to Paxlovid, you have to have a positive result. It's not indicated for prophylaxis at this point. You have to have a positive result to qualify for this one. And the dosing regimen, adverse reaction profile is similar to Paxlovid, maybe a little minor than that. And again, it's not tested for pregnant and breastfeeding women, so you cannot use it at this point. So the other agents that we have is the monoclonal antibody. And here we have two agents. One is used for treatment after you tested positive. One is as a prophylaxis. So Evusheld is a mixture of two monoclonal antibody, which is tixagevimab or silgavimab, is a prophylactic agent that we have. And bebtelovimab is actually the one that we use for after you have tested positive. And we have some honorable mentions for some monoclonal antibodies that have been used in clinical setting for about, until last maybe a month or two. Now they're not indicated. Their emergency use authorization has been revoked, and primarily because they're not catching up with the emerging new variants. Their efficacy has continuously deteriorated, so they're not used. But believe me, there was a study that came out 3 weeks ago. Quite a number of healthcare settings are actually using them. I'm not sure if that is because they couldn't get access to the bebtelovimab, or if it's just we have it in our stock, or we will continue to use it. But that study was really an eye-opening. After revocation of their emergency use authorization, people continue to use them when they know their preventive ability is much decreased. So Evusheld, what is the evidence, supporting evidence to use as a prophylaxis? So this is a PREVENT study, and it's an ongoing clinical trial. Actually, it's not completed yet, but the preliminary analysis was the safety profile was incidence of adverse events. What are the adverse event profile? Is this well tolerated or not? And the primary efficacy endpoint was the first episode of symptomatic COVID incidence. And as you can tell in the graph, the difference is not really significantly high between the placebo and the Evusheld. But if you blow up, you can see some level of difference. You have 1.8% of patients on placebo having symptomatic COVID infection, while only 0.3% of patients on Evusheld actually have symptomatic COVID infection. And again, none of the vaccine nor the monoclonal antibodies are going to prevent infection. The only job they will do best is they will minimize the risk of disease complication. And also they may minimize your shedding ability of the virus, so that you may not be able to transmit the virus into other people as well. But nonetheless, this is significant data enough to use for certain part of the population. Again, I'm going to repeat this one again, because this level of difference in incidence is not observed in the whole general population. If you have a healthy young person, they probably will not get maximal benefit out of this one. So you actually might as well just monitor them closely and see if they will ride it or if they will progress into more disease complication. And at that time, you can intervene. And as a result, this medication is indicated for pre-exposure prophylaxis only, not a therapeutic option. If you have positive test, then you cannot use this medication. There is no data to show us this is efficient in managing COVID positive patients. If they haven't had any recent or close contact with someone, haven't had any recent or close contact with someone who's tested positive, because at that point, you're looking into the incubation period. The more that we have variants now, the incubation period is shortening, so you have a better chance of catching the infection through test. But there is a chance that you might miss the test where you will have false negative result if they are in the early incubation period. And it depends also what kind of test that you're using. So if someone tells you like, I have my brother who sleeps with me on the same bed, tested positive for COVID yesterday. So you probably have to hold on and do your tests and give them a few more days before you start this one. Because if you give them this one, essentially you're excluding them from using another therapeutic option, because there is no study to demonstrate safety of using two monoclonal antibody of different indications within close proximity to each other. Moderate severe immune response compromised. If someone healthy, like I said, is not indicated. If you have someone taking immunosuppressive patients or medication or immunocompromised patient, then this is indicated because they have a higher chance of disease complication. Or if you have someone who cannot take the vaccine, I have one patient who had pericarditis, and before the Novavax came out, he was totally against the Johnson & Johnson, and there was initial signal of the pericarditis and myocarditis, and this patient had the first vaccine, and he did react to that, and he doesn't want to get the second vaccine, which I support. At that point, when we have the Evusheld, the first person we called was that person, because this is severely disadvantaged patient because of his precondition of pericarditis, and you cannot re-challenge them with the mRNA vaccine a second time when we know he has already reacted severely to that one. The initial dose for Evusheld was actually 150 of each monoclonal antibody, but soon enough there was a study that suggests that probably is not a high titer enough, a high dose enough to counter the disease progression. Though after 3 or 4 weeks of the initial approval, dose was doubled to 300 of each. So now it's 600 milligram of the Evusheld, and now it's also indicated to be repeated every 6 months as long as we are in the pandemic phase. The adverse drug reactions are mainly injection site reactions, headache, fatigue, and cough. In the initial phase, we were actually monitoring patients for 1 hour after injection to see if there's any delayed reaction. But at this point, patients have an option to either wait 10 minutes or leave home after the injection. And use in a specific population. This is, again, there's no clinical study done in pregnant women or breastfeeding. As a general principle, monoclonal antibodies are safe, but unless you have data to suggest that is actually safe, then you have to have a close, shared decision making with your patients and their gynecologists at this point. The second monoclonal antibody we have is bebtelovimab, and this is a recombinant neutralizing antibody IgG1 lambda. And there is a breeze for a phase 2 clinical trial. This is a randomized. So the treatment actually in the initial phase was compared with placebo as well as with a combination of 2 other monoclonal antibodies. You have the bamlanivimab, you have the atezolizumab and bebtelovimab combination. You have bebtelovimab and placebo. And the data, the result was, the primary endpoint was to see if there is a persistent high viral load. It is not disease complication prevention. Persistent high viral load. And as you can tell here, there is marginal or maybe numerical advantage of bebtelovimab when it comes to the persistent, and this is at day 11. But if you take a look at the secondary endpoint, which is mean average of viral load, and at day 5, you see a clear difference between the placebo and the 2 monoclonal antibody combination, the 3 monoclonal antibody combination, and as well the bebtelovimab as well. And that was significant enough for patients who are at a high risk of disease complication. If someone have a persistent high viral load, that can trigger the cytokine storm syndrome. So you better prevent that from happening instead of waiting, even though the endpoint at day 11 shows you practically not statistically significant in both the primary and secondary outcome. In the meantime, like at day 3 to 5 or day 3 to 7, you have a significant difference in the viral load, in the mean viral load. So that was significant enough evidence to recommend this one to patients on a high risk of disease complication. This is the data I showed you is on patients with low risk population. If you take a look at the patients with a high risk population, which have underlying disease complications, and in this case, we're only simply comparing the the bebtelovimab versus the 3 combination medication. And the same trend you can see here, actually, there is a difference between the combination 2 as well. So even though bebtelovimab had better, at 5, the end result at the end of the clinical trial was almost non-statistically significant. So adding 3 monoclonal antibody together probably is not going to be giving you a better option. In fact, at day 5, you have the monoclonal antibody doing the job itself. So for that reason, bebtelovimab is persistent to be the recommended medication for post-COVID infection treatment if you cannot use the oral antiviral therapies, or if you prefer to use this one. Indications, again, it mirrors the same indication profile with the oral antiviral therapies. You have to have COVID positive test and other eliminating factors. And this one gives you a little more time as opposed to 5-day cutoff. You have 7 days to start therapy. The previous monoclonal antibody that we mentioned as honorable mentions, they have at least 10 days window you can start therapy, but they lost their efficacy, so they're not using anymore. If you have someone who at day 6 of initial onset of symptom, which is a candidate for both oral antiviral and monoclonal antibody, at this point, I would prefer the monoclonal antibody because I am out of the window of the clinical efficacy of the oral antiviral therapies. So the question now is, we're talking about variants, and is bebtelovimab holding against the new variants? The good news is it is. So at the lower part of this slide, you're looking at the BA4 and 5 and BA4.6. The BA4.6 is the new variant that is expanding now. It has about 13% circulation in the United States, and it's demonstrating significant difference in response to the vaccines that we currently have. But fortunately, bebtelovimab is holding its ground against these variants as well. So this is a good news for us. Essentially, the mutation or the variants that are emerging are not negatively impacting its efficacy. The other therapeutic option that we have, and primarily these are used in an inpatient setting, mainly to prevent cytokine storm syndrome, are the immunomodulators. And the principle here is, left of the slide, you're looking into the natural viral cycle. The viral infects the cell, multiplies itself, uses the cell machinery to multiply its genetic material, and it creates new viruses and continue infecting others. So when it's infecting other cells, cells always will send a signal to the immune cells saying, hey, there is something going on, we need help to clear this foreign substance. So you have the direct activation of the lecithin pathway first. You have the immune complex of the complex 5 and 3 and 5 mainly involved in immune response. You also have the toll-like response activating. All these things will activate the complex syndrome and activate your neutrophils and macrophages. They will be recruited in the site and start the immune response, how do I say this? In conjunction with the T cell response. So when you have the neutrophil and macrophage activated, your cells are now going to send a signal. And this signal is primarily the interleukin, or we call them cytokines. These are pro-inflammatory cytokines or chemokines. They will circulate in your blood and keep alerting your immune system. Okay, there's an invader, so we have to recruit 1, non-specific T cell response, and 2, specific B cell response to generate antibody. But the question is, can your body control this immune response? Our immune system is designed, or is quite tightly controlled to respond to invaders in proportion. When the immune response is out of control, if it doesn't auto-regulate itself, and it does more of a harm than a benefit, and that's a term where we call cytokine storm syndrome. At that point, you have like uncontrolled cytokine, definitely pro-inflammatory cytokine release in the bloodstream. Not only the lung is affected, all the other organs, essential organs will be affected. And for the most part, people will be dying out of that cytokine storm. So I just put this one just to give us like a bird's eye view what we're looking for when we're using the immunomodulatory medications. Not necessarily for their antiviral therapeutic effect, but because of the cytokine storm risk reduction contribution. So in these medications, I probably will not go into more details of the dosing and stuff, primarily because these are one used in critical care or emergency situations, and the dose will always differ based on patient population. But I will just capture the whole essence why these are working the way they are working. To me, to begin with, any steroid therapy that we use, I call them fire extinguishers. So steroids will work in two ways. One, they will suppress your pro-inflammatory cytokine production, and also they will increase transcription of the anti-inflammatory cytokines. So not all cytokines are equal. There are cytokines that are pro-inflammatory that will always can trigger the immune system. There are also cytokines that will help your immune system regulate itself. So steroids, dexamethasone being one of them, does the job by eliciting these two balanced actions. When you have the dexamethasone bound into the receptor, it will first internalize in cytoplasm, and the glucocorticoid receptor will actually translocate into the nucleus and regulate the transcription. By regulating transcription, like I said, it will suppress the pro-inflammatory cytokines like interleukin-1, interleukin-6, interleukin-17, TNF alpha, or many other. There are hundreds and thousands of them. But also, it will also increase the transcription of certain anti-inflammatory cytokines, primarily interleukin-10. On the other hand, on the left side, you are also looking at the other part of the cytokine. Glucocorticoids actually shut off the MAP kinase signaling pathway, which is also indicated in generating more of the cytokine production. So they use this to balance the arm to regulate your immune system, so saving you from your immunity attacking yourself. The other class of medication, out of the class of medication that we use for this purpose is baricitinib. Baricitinib is marketed as an Olumiant. This is primarily indicated now for rheumatoid arthritis or psoriatic arthritis, in some cases for alopecia areata or atopic dermatitis. The reason behind this medication also is the same. So the JAK-STAT pathway in our cells is an intracellular signaling pathway. What it does is, once activated, it recruits STAT molecules and it regulates transcription of the same pro-inflammatory and anti-inflammatory cytokines. So what this baricitinib does is it blocks the first phosphorylation step of that signaling cascade. If you block that phosphorylation cascade, then STAT molecules will not be recruited into that, and they will not be activated, and you do not have all these pro-inflammatory cytokines released and continue to have these cytokines stored. And the JAK inhibitors have many classes, out of which the four more important physiological are the JAK1, JAK2, JAK3, and tyrosine kinase 2. And baricitinib actually inhibits the JAK1, JAK2, and JAK3, the three of them. So it's not a complete shut off, because as you can see on the right part of the slide, these JAK receptors actually have a physiological function. So you don't want to shut them off all, but it regulates the function of this JAK receptors so that you have a controlled release of the cytokines. In a way, it balances your immune response between pro and anti-inflammatory. So baricitinib is mainly used for that purpose. It was tried for antiviral function, it didn't work. The third medication that I want to mention is tofacitinib or actamrozin, injectable medication, sub-Q injection, as well as IV administered. And this is anti-IL-6. In the previous slide, I mentioned that the pro-inflammatory cytokines mainly currently identified to contribute significantly to the cytokine storm are IL-1, IL-6, TNF, and TGF, interferon gamma as well. These are the four most commonly seen in the cytokine storm. And IL-6, interleukin-6 is one of them. And it's important, it's quite significant, because interleukin-6 receptor actually regulates three different major signaling pathways in our intracellular system. The PI3 kinase, by which it will be activating the diacylglycerol. Again, the same thing. It will translocate in the nucleus and regulate transcription of this pro-inflammatory cytokines. And it also, similar to the glucocorticoids, it also modulates the ERK and MAP kinase signaling pathway as well. And that's one of the major signaling cascade that regulates our cell function as well as inflammation. And the third part is the JAK-STAT pathway. So in the previous slide, we specifically saw the baricitinib and its role in the JAK-STAT pathway. IL-6 actually covers that signaling pathway plus two additional signaling pathways. So it's really powerful, and currently it's used for, I'm not sure if everyone heard about the CAR T cell for oncology gene therapy. So there's significant risk of cytokine storm if you're using that therapy. And tofacitinib is one of the candidates for that cytokine storm when you are treating cancer patients with the CAR T cells. And it's been tested for COVID, and it did a good job in managing the cytokine storm. So what other factors do you want to consider when you are selecting treatment options? I probably am repeating myself here. I probably have said this one multiple times. Time from initial to treatment onset and symptom onset. If you are within the first 5 days, oral antiviral therapies are probably a good option because of the access. The monoclonal antibodies, you have to have a hospital setting or a clinic setting to give it through IV or IV push injection. It requires a specialized setting to get it. Comorbidities are really important. Facility accessible. If you have someone in a rural area that don't have any close by clinic, probably oral antivirals are going to be really essential. Current medication list. This is also important for the drug-drug interaction as well as the efficacy of the medication. Sometimes you don't want to give antiviral medication when you're also giving them immunosuppressive medication, which you are countering the effect as well. And pregnancy is one of the things that you should consider in all these conditions because we have very few data to suggest the safety of these agents in pregnant women and lactating women. And this is a broad summary of things that I already spoke, or maybe I didn't speak already. This is a guideline that was updated by CDC last week. I probably will share this slide decks with you all. So if you have patients, I think masking is one thing that I didn't speak yet, and I cannot emphasize more about that because mask is probably the best option, the first line prevention that you always have to recommend patients, especially if they are at high risk of disease complication or contracting the virus due to their nature of lifestyle or work. We have all the summary that we spoke, and just in the interest of time, I will just make it shorter. I'll get to the really important point that I think would be more interesting to all of you guys as pharmacists. What is the test to treat initiative and how are you guys handling? I think most of you probably are practicing that initiative as well. So when it comes to the patient care, I think there is nothing second to that because we know so far from the vaccine COVID rollout and other clinical healthcare provisions initiatives, a lot of our patient population do not have easy access to healthcare settings. By far, pharmacy is the closest healthcare institution they can access quickly without any delay or complication or barriers. So empowering pharmacists, which we already are trained for, to handle the testing, and we're already doing the testing at the pharmacy level. If you're doing the testing, having the standing order for Paxlovid or other antiviral therapeutics is not something that require additional training because we've done that several times with the pandemic with the addiction epidemics. Most pharmacists actually now have standing order to prescribe and dispense Narcan, which is an antidote for overdosing. This will be the same because if you treat someone tested positive in your pharmacy, and okay, now you tested positive, you have to go to see your PCP, and good luck this person holding their PCP in a short period of time without running out of the treatment eligibility window. And worse, the PCPs sometimes are not quite equipped to prescribe this medication. They will send you to other like infectious disease experts. So in the meantime, the patient will run out of their eligibility times, and at the end of the day, they will be having adverse event. So pharmacists are well positioned to address this pandemic, and we have already demonstrated our capability when it comes to vaccination. Pharmacists hand down has probably the most vaccine roll out and reach out to patients who are disadvantaged by far. And for the pharmacy practice, and this is what I alluded earlier when the AMA signed the petition to FDA and CDC to prevent this test to treat from taking effect. They're not concerned about the drug-drug interaction that they mentioned, the 6th page of drug-drug interaction. No, actually, we are better positioned to address that drug-drug interaction more than any specialist in the field. That's what we are. We are drug experts. But they are actually lobbying Congress and every institution that you can have from preventing pharmacists gaining that provider status recognition. If we have that provider status recognition, then we will be able to build insurances for our professional services. Currently, pharmacists, be it in an outpatient setting, a retail setting, we do educate patients. That level of education we provide, if it's done by a clinician in a hospital setting, that's billable to the insurance. They charge for that, but we do not, because we're not recognized as a federal provider status. So I think the more we push for this one, and the more we show our excellence on this front, is when we get the opportunity, that will give us at least 1 or 2 steps closer into getting the federal recognition level as providers, and that we will be in equal footing to actually get paid for what level of service what we provide. And with that, I think I probably have gone a little over the time that I planned to, but I'm truly passionate about these subjects. That probably is the reason. Thank you for your patience. I will open the floor now for any question if I'm able to answer them, but more so for discussion. I am sure most of you have significant level of experience on this one so far, and the floor is yours.
Thank you so much, Dr. Amanuel Kehasse. This was a very insightful presentation. The floor is now open for any questions or feedback. I see a raised hand.
I think Dr. Hebrangus has raised his hand.
Okay, please, Dr. Hebrangus, go ahead.
Okay, thank you, Amanuel. I don't want to miss actually this opportunity to appreciate, your presentation. I am so proud of you, and this is really an excellent review. I'm sure we are going to prepare a review paper out of this because it is very comprehensive. So after that, I have a couple of questions. One is from on the immunization side. You have been explaining, the immunization options that we have, in the fortunate countries. What do you think about, the population that do not have any access or little access to vaccination? And where do you see the impact of epidemic? And, are we anticipating, in the absence of immunization, the natural immunization will take over, and hopefully we can rely on that? This is one question I have. The other question I have is on the antiretroviral agents therapy, Paxlovid. The tests have been, or the clinical studies have been conducted on people 12 and above, and you have stated that actually the benefits is more observed on people who are above the age of 65. And do you see any benefits for the pediatric population using this therapeutic agent? Thank you.
Thank you, Dr. Hebrangus. I really appreciate the kind words, and I'm glad specifically those coming from the educator that shapes me to be who I am right now. So actually, part of the credit goes back to you. Thank you so much. Yep. So the first question, I think I will see it as an equity, as a case of equity. Actually, we always say that no one is safe until everyone is safe, right? And that goes to show the level of inequity that we have globally, not only in the United States, not only in the European countries, but globally. I will start with because it's better to study, to talk about data to support my idea. In the United States, there was some studies that was conducted, regional studies, the Midwest and the South states of the United States, and the like I will just categorize like the progressive states versus the conservative states. There was a lot of hesitance when it comes to the vaccine adoption on those states. And the infection rate and even the days rate were much, much significantly higher in those states, the non-vaccinated population. But this notion can also be extrapolated into those people who actually didn't get a chance. Not these people actually refused the vaccine, right? But there are a significant part of the world population who didn't actually get the access. So the same thing will happen. They will have more of an infection, and if we know anything about any virus, the inherent characteristics of the virus is they will continue to mutate and change their behavior. So if you have some part of the world pocket not vaccinated or not have access to the vaccine, the virus will always continue to circulate in that population, and new variants will come, and lo and behold, it will actually come here and attack us. So what I wanted these developing nations to do is, and I can support this one with data as well, instead of giving patients multiple doses of boosters, it would be a good initiative to actually spread these vaccines into those populations who did not have access. The reason is, some studies actually showed the fact that we are having more infections as we go, like for example, 6 months after the second dose of the booster or after a year of the vaccination, there is a natural tendency of immune system winning, right? But more so, it is not the immune system that is declining, that is giving us more of an infection. It's more of the emergence of new variants that is creating new infections. So a lot of people tend to focus on immune system is like winding down. Let's give it a booster. Let's give it a booster. Of course, giving a booster will give you a little more protection, but that's not the primary reason that you're having more infection. It is primarily driven by the variants. And the only way to control that is to make sure that everyone get access to this vaccine. So with that, I will always advocate, like, if there are nations that are not able to get this vaccine when they want it, we should advocate for them to get equal access, like equitable access. If there are nations who are not willing to take it, then we have to still advocate for that and just knock the doors all the time to those decision makers. Hey, your population need this one, because it's not only your population that you're harming, but all the general population in the whole world, you are going to affect it. So with that's how I see it. So there is no question, everyone have to have equitable access at this point. The second question in regard to the antiviral therapies, yes, it's not tested for the younger age yet. But the second question, actually, I may rephrase these words, but it is not my idea. I want to give this credit to one of the panels that advise FDA and CDC on these therapeutic approvals. His name is Dr. Paul. He's one of the scientists he's a pediatrician. And I'm quoting him because this question was more of related to the pediatrics population. He's one of the 2 advisors who voted no for the COVID booster vaccine. And he had some concerns with the antiviral therapeutics as well. So the reason for the COVID vaccine booster, the bivalent, is data that we haven't seen it yet here, but data that he has access to. He saw beyond the titer, the antibody titer that we discussed it today and published it elsewhere as well. Does it translate into clinical efficacy? Does it actually prevent disease complication and hospitalization and death? So one question that we don't have the clear answer to is what level of high titer is protected? What is the cutoff? We keep increasing the titer by giving boosters, but do we know whatever we have, is that not protective enough? And like I said, I'll come back to the reason why we are having more infection. It's more of the variants, not the immune system weakening. So considering all these things, given more of the vaccine, when you do not have the clinical efficacy data is questionable. And in his case, because he has seen data showing like the ancestral, the vaccine that was designed against the ancestral COVID, the original COVID vaccine, actually have comparable prevention efficacy against severe disease complications. So yes, we see significant difference in the antibody titer and the neutralizing antibody titers, but the clinical efficacy is not that different in both cases. So why are we combining these two? Because the combination again is half of half. So you're not even given. And he actually tried to justify this one by going into the core science. When you're given a booster, the whole idea is to wake up the already initiated immune system, the memory B and T cells. But when you're given the second part of the booster, which is the new mRNA vaccine against the circulating variant, that doesn't actually do much the already memory B and T cells. It actually goes to the germinal cell and activates new ones. So in his justification, this bivalent probably is not the solution. We should actually focus on the current circulating variant, because we already also know if the antibody titer is a measure that we go, it also covers us for that. Because if you see the data that we have seen, the antibody titer for both is the same. There is no significant difference. I'm going back to that slide just to have a visual comparison. So we're looking at here. Against the ancestral, the antibody titer is virtually similar. So focusing on the current circulating variant, and instead of combining them, just use the higher dose of the current would be just fine. The second part is the antiviral therapy. All the antiviral therapy that we tested so far, they have a modest efficacy level when it comes to the general population. But there is a significant difference when it comes to the high-risk patients and patients who have comorbidities. But if you do subclass analysis, but if you see the data that they did the subclass analysis, I don't want to take credit for that. Patients on the younger age, actually, there is no statistically or even numerically difference in their admission to the ED, whether they take the Paxlovid or not. To begin with, they don't have a high risk. And at this point, there is also a distinction that we should make. When we are at the height of the pandemic, when anything and everything could be possible, it could be justified to try just risk reduction. You want to actively reduce any unknown. But at this point, we are at a much better phase in the pandemic. And to begin with, and to add to that, they are not at high risk to begin with. I wouldn't advocate for those population unless we have a clear data. They are at high risk of disease complication and death, and Paxlovid will make a difference. And again, there's always the side effect profile that we have to consider. So we're just giving them when there is no clear clinical benefit, but we're exposing them to any unknown side effects as well. So it warrants a significant discussion, and ultimately parent, physician, mutual decision-making discussion. At the very least, what I wanted to do to my patients, I want to be honest. I want to tell them all the evidence available, and I would empower them to make the right decision, and I will support them on that decision. I hope I answered the questions, right?
You did. Thank you.
Thank you. Any other questions or any feedback?
I have a question, Ahmad.
Yes.
First of all, yes, thank you again. for this really comprehensive presentation. My question regarding the protein vaccines. What is their place at this time? I saw I joined a little late, so I saw one slide where you mentioned one of the protein vaccines, but after that they were never mentioned. So what do you think is the place for those protein vaccines at this time?
So yes, I mentioned the Novavax, which is the most recent addition to our armamentum. I think there was other protein-based vaccines, like I believe the AstraZeneca, mostly use it in Europe. They are being used, especially in the South American part of the world. They're using it, and their clinical efficacy is actually good. They're not any less effective. We just spoiled that we have a lot of supplies with the mRNA vaccine, and we already have demonstrated quite significant success in mitigating the risk of COVID complications, and we are taking comfort. But now that we have the Novavax, Johnson & Johnson, there was that blood clot risk that scared everyone, and their clinical efficacy when it came to the booster was not actually great. So Johnson & Johnson it's the viral infection. I'm just digressing from your question, but I just want to address that one too. I missed to address that one part earlier. When they tested the COVID booster, people who got the Johnson & Johnson didn't respond as much as the others when it comes to their antibody titer, whether you give them a second J&J or whether you give them the mRNA. So they quickly, they just fall out of favor. Their clinical efficacy just went. The Novavax is relatively new to us in the United States. This is the first one that we are actively using. We don't see that much use it because, one, the vast majority of our population is already vaccinated. So we're not talking about the booster. And Novavax is not indicated for booster. Booster at this point, except for that 5 to 11 year range, which you have a third, the Pfizer booster. There is no other original vaccine that is indicated for booster. The booster at this point is, regardless whatever you started with, it will be the bivalent. So I don't think them getting much of market attention, but clinically, the data is clear. They're as effective as the mRNA vaccines.
Even for the new variants, or?
We don't have data for the new variants. The
how about mechanistically? How about mechanistically, by the nature of just being protein vaccines, do they provide more broader coverage compared to mRNA?
I believe so. Reason is specific, especially if they, I still have to look back into their components, if they are only the spike protein, or if they also include the nuclear protein, which also may display on the surface. If you have a vaccine that targets both the surface and the nuclear protein, that tends to have a wide range of broad, because for the most part, the anti-nuclear protein, they're very conserved. So even though you have mutations going on, the anti-nuclear protein or the proteins that are targeting nuclear components are, for the most part, preserved. So I would imagine, I probably would believe that they will have a broader coverage for the new variants, just simply because of that background information. But we will need to see more data to see. But before I forget, there was a study, I believe it was in South America, one of the South American countries. Don't quote me on this one. I'm just getting fuzzy and remembering that study. But they made a little mistake and combined the protein-based vaccine with mRNA, and they had actually a better response as well. That didn't advance into a full-fledged clinical trial, and there was a similar situation with one of the vaccines, similar situation. But my intuition would be, I think we probably will have a better, broader coverage. Probably it will be difficult to manipulate now and then, given the complexity of the process, we'll probably be better off to have new vaccines generated with the mRNA technology. But once you have it, you probably will have a little more protection. I believe, I'm not sure if that is 100% right.
Would you recommend this protein vaccines for patients with higher risk for cardiac inflammation and or patients who might be generally hesitant with mRNA vaccine?
I do actually. Actually, one of the attractive features of the J&J was it was relatively closer to the old technology than the mRNA vaccines, and people tend to adopt the J&J comparatively. I think they had more trust to the established workflow, and I definitely would recommend the Novavax or the protein-based vax for the patients that have the pericarditis side effect. That's probably mainly seen in the mRNA vaccines. Always no two patients are the same. So we always have to factor in what are the risks and benefits for this patient, whether I give them this one or the other. And now that we have access, probably I definitely will consider them for those patient populations. And trust is also important. For example, if we are sending this one to a population that has probably less information and they have significant misinformation about the mRNA vaccine, it will kill us, all the side effects, all the conspiracy theories that we heard. If that is a deterrent, and Novavax probably will be our savior. Just demonstrating this is the usual vaccine process, so they probably will have more buy-in to that.
Thanks, Ahmad.
Thank you. I see a raised hands from Mulgeta. Go ahead, Mulgeta. And then Dr. Salam, you can go afterwards.
Okay, thank you. Thank you, Haikel. Dr. Amanuel, I'm really impressed with your, first of all, with your career progression. It's really an inspiration for all of us. And the other is, I'm very happy that I joined today to this update on COVID-19 vaccines and therapeutics, because the comprehensive is very detailed, as Dr. Ibrahim rightly said it. And I really have learned a lot from what is presented today. And my question here is, of course, vaccine hesitancy is everywhere. I can say that, and which might be, possibly triggered with a lot of factors. One might be conspiracy theories that have been made against the COVID-19 vaccines, and the other is the time that it takes from the conception up to marketing. That is, the emergency use licensing has also created a huge, insecurity. And also there are uncertainties regarding the benefits and risks, because we are, the world is at one time getting the vaccines, and we never know what will happen. There are such kind of uncertainties or insecurities, and also which might be maybe okay. Of course, the world is uncertain by itself, but with this, there are people and also institutions that could not dare to get the vaccines. So basically here, what's really your recommendation for institutions or individuals who are hesitant of the available vaccines? And do we really need to, fear of these vaccines? And my second question, comment is, you have mentioned some safety signals as well. Of course, with the wider use of these vaccines, we will see a lot of safety signals that are related to the available vaccines. But it's also likely that these safety signals are being misinterpreted even by healthcare professionals, because there is an assumption even from experts that when a safety signal is flagged out, they might assume that there is a real cause-effect relationship. but it's not. Because a safety signal, by definition, is a hypothesis that is supported by data and arguments, which really triggers for further studies. So with these misunderstandings, and also you have mentioned it rightly that whenever you see a safety signal, you need to ask yourself what is really the background risk of this adverse event, and also what's really the risk of the adverse event related to the vaccine and so on. So I really thank you, Dr. Amanuel, and over to you, Haikal. Thank you.
Yeah, thank you. I think with the first question, institutions and individuals, I think I'll try to look at them a little differently. Individuals make decisions that primarily affects them, even though it will also affect people who are across and around them for sure. But primarily they make their own decisions. So it is, you have to individualize that communication with them. Okay, identify the problem. Like, for example, again, the concerns in different parts of the world will be different. But here, trust was one of the key reasons that people were hesitant to the vaccine. And I work in a hospital that primarily serves the underserved community. So we proudly say we are the largest hospital, like health safety net hospital in the region, in the New England, primarily because most of our patient populations are either immigrant population or African-American population, or whatever, like it could be socioeconomic underrepresented patients as well, right? So throughout the time, these patients either have been hurt by these health institutions, not hospitals per se, but by the whole overall healthcare system, or maybe ignored. Hurt, when I say hurt, we all remember this Tuskegee experiment. It's always repeated. What it does is the government of the United States actually did an experiment for syphilis on patients without their knowledge. And worse is they were not even given the antibiotic when it was available for treatment option. So this is a huge human rights abuse or violation. And that's always repeated, but there are countless incidents where patients were mistreated or taken for granted for certain things. So there is that notion, okay, this health system, this is corrupt. We don't trust it. Whatever you have it, just do it. And there's also that they've been long ignored. For example, I'm only picking an example that I know a little better than others. I mean, from my knowledge base, not other people, but from other circumstances. There has been a wave of addiction epidemics in the United States, right? So cocaine use, all this illicit drug use, addiction epidemics. Back in the days, it was primarily affecting the people of color. And how the government and health institutions handled that was as war against drug. Essentially, they were arresting people. Essentially, they were punishing people who are victims of this epidemic. And an epidemic that was actually created and perpetuated partly by health care industries advocating and promoting unsafe pain medications. All right, so that was the response. And now that epidemic has shifted into different patient demographics. Now, much of the epidemics is affecting the Caucasian or maybe the upscale communities. And now it is an epidemic that is worth medical attention, not war against it. And a lot of healthcare and government attention is being provided to that. So what do you think this color community will think about this approach? Yeah, you ignored us when we had that pandemic. You arrested us for having a small amount of it. but now it's like a public health emergency, not a crime. All this and others, countless others that I don't know, plays a factor on their distrust of the institution. So partly what we did, I think, from our institution, because we serve these communities primarily, we actually went into their communities. We worked with their pastors, we worked with their community leaders, and we actually opened vaccine clinics in their neighborhood. Then we were open for them to ask us questions. That created a lot of trust. And also they have seen the epidemic was primarily affecting them because of their comorbidities, the socioeconomic situation. They were the primary victims, and then shunning the vaccine probably would be a second insult to the injury that they're already getting from the pandemic itself. So you have to really communicate with them at the level where they are individually. When it comes to the institutions, that's a different dynamics, because these institutions are not necessarily deciding for themselves. They're deciding on behalf of the patients or the population that they are governing. So the level of communication with them would be different. Just letting them understand. For example, if I'm talking about a government, for example, the primary role of a government is to keep the well-being of the population and the nation, health-wise, economy-wise, security-wise, whatever it is. They always have to guarantee that people and the country is safe and healthy and prosperous. COVID smashes three of them at the same time. Economy, it will be devastating if COVID persists. Patient safety, without any protection and COVID prevention or therapeutic options, people will suffer. Your economy will suffer. National safety or security, if you do not have healthy and prosperous people, national security is not going to be guaranteed to be intact. So you have to actually hammer all these important factors that probably will matter more to them. If their government, they want to stay in power for as long as they might want. So for them to be in power, healthy, and succeed with their work, they have to look after the population. If they have questions, definitely there is, like I said, any publication or any knowledge is not guaranteed to be perceived by everyone the same. Any question, honestly address it. I cannot honestly say to my patients or to anyone who asks me, these vaccines are safe, don't worry about it, just go and take it. No. Okay, I know these vaccines are safe to a certain extent, but what is your situation? What is your question? What's your hesitancy? And specifically address that one. Does the patient think that the vaccines or medication didn't go through rigorous scientific study? Educate them, empower them to know a little more, and then they will buy into your ideas. I think the approach will be totally different for both institution and individually, but at the end of the day, it comes down to educating them and empowering them to make the right decision for themselves.
Thank you, Dr. Kehasse. If there are any other questions, please go ahead, Dr. Selam.
Hey, yeah. Thank you, Dr. Aman. Yeah, actually, Tuskegee, the place where the civil study was done is around 20 minutes. Yeah, it's actually 20 minutes from where I live, very close by. Yeah, my question is regarding getting the booster after. You might have discussed it, I might have missed it, but what is the timeline and guideline for the second booster after if you have got COVID?
So the current guideline, the previous guideline has completely changed a few weeks ago once we have the bivalent approved. So now we are primarily looking on the timeline when you will get the bivalent vaccine for people of age 12 and above. So the guideline will say at least 2 months from the last vaccine, regardless how many vaccines you had. The minimum requirement is you need to have at least 2 doses of the primary series. If you have 2 doses of the primary series, you are qualified for the booster with the bivalent. The monovalents are not anymore available for booster for adult, like for adolescent and adult, except from 5 to 11 and that is with Pfizer only. So 2 months is the minimum requirement, but clinically and scientifically speaking, 2 months for a booster is a little short. Meaning you have, when we get the, I'm sure you guys remember the immunology, like the first immune response is quick, which is the IgM antibodies response, which happens quicker and just winds quicker because that's temporary protection, the IgM. And you have the second wave of IgG-based antibody development, usually 2-3 weeks later after the initial vaccine. So that comes up in plateaus for a long period of time. So when you are trying to boost it, you have to give it some time for the immune system to actually acquire enough memory cells. The booster, the main function of the booster is primarily to reactivate the memory cells to generate more antibodies. That's why you have a more quicker burst in your immune response. So for that reason, give some time for the immune system to stabilize and acquire enough T and B memory cells, and then you will have more robust cells. If your intention is now to generate new germinal B cells that has not been provoked yet into generating new antibody lineage, and then giving them at 2 months probably is not a good idea because you're not targeting the memory cells, you're targeting the germinal cells. And that's part of the justification that they combine the booster into half and half, like half of it will reactivate the already primed B and T cells, and half of it will go to the germinal cell and then initiate a new wave of B and T cell line memory cells. So 2 months is the guideline as a recommendation, but recommendation, if we have learned anything yet, any recommendation that comes out should only guide you, not determine always you have to be within the boundaries of the recommendation, but always follow the science and get it, because there is no maximal limit. Don't take it like, it doesn't say you have to take it between 2 weeks and 6 months. There's no that maximum limit. The longer you wait, as long as you think you are safe and protected at that time frame, the better boost you will get. And that has been demonstrated in clinical trials.
Okay, thank you, Dr. Amanuel. Yeah, and I have one question as well. So in terms of pharmacists being involved in prescribing COVID medications, I feel like that's a double-edged sword. In one way, it's great for pharmacists to be involved in patient care, but in the other hand, pharmacists have to fulfill all these metrics, especially pharmacists who practice in community setting. They have this company metrics. They have to fill this many prescriptions. They have to do vaccines. They have to do a lot of things. So how do you reconcile this without like advocating for pharmacists to provide care while not contributing to pharmacist burnout?
Yeah. I think that's a great question, because probably that is one of the bottlenecks for the pharmacists from like wanting to grow professionally and meeting to or satisfying their requirements, right? So in a community setting, it is really, really challenging unless that retail, like, I don't want to say retail, but that community pharmacy has incorporated patient care system in like part of as the metrics. That may work, but the way it works now is prescription volume, right? And reason is because the managers or the leaders of those chain pharmacies only value the revenue. They always, your metrics is numbers, but at the end of the day, it is amount of dollars that you generate for that pharmacy. The number of prescriptions will translate into money. If the government has actually put a reimbursement process for these services that will actually serve better for this institution that they are asked to actually to dedicate their pharmacy manpower into these services. And that could be an initiative that pharmacists will be wholeheartedly endorse. The pharmacists will be happy, and the chain pharmacists will be happy. But at the end of the day, we are doing it anyway. For the most part, I think, especially in the hospital settings, we're doing it. It's much easier because it's part of the clinical care. But in the pharmacy settings, this is part of the cost that you pay. If you really wanted your pharmacist to advance professionally and ultimately serve your patients, if your patient care is part of your primary goal as a pharmacy chain, then this is some of the price that you have to pay to advance their professional career. And finally, they will get the provider level. And I'm sure all of you know now, CVS, Walgreens, and the big ones, they actually have nurse clinicians in pharmacies. The reason they have nurse is because the pharmacists cannot do certain things legally. While professionally, they are able to do that, but legally, they cannot do that. So they have to hire another person, an additional person, to give clinical services at the pharmacy setting. So they are reframing their setting into more of a clinic than a dispensing settings. So if they empower their pharmacists, they probably will not need to bring another nurse. I can give you a typical example. Pharmacists in a retail setting, they are authorized to give vaccines, right? In my settings, I am able to give COVID vaccine. I'm able to give COVID vaccine in my clinical setting and other clinical setting, but I cannot give pneumonia vaccine in my clinical setting because that's a regulation. It's not that I don't know how to do it, because I'm doing it anyway somewhere else, but I cannot do it in my clinic. And when I say in my clinic, if I'm doing it at a hospital in the COVID clinic, I can give vaccine, but in my clinic office, I cannot give COVID vaccine. So all these regulations there's interprofessional relationship, interprofessional competition, or professional competition that always happens everywhere. So the pharmacists and the chain pharmacy owners have to really invest and pay some level of price to get this hurdle of the provider level. Once you get there, and then everything that you do, probably the billing that we will generate through patient service will outpace the prescription volume revenue they will get, and we'll have more of balanced metrics to have. But I hear the challenge.
Okay, thank you so much. We have one more raised hand. Our time is almost over. I will give the mic to Dr. Debesai. Go ahead, please.
Thank you, Haikal. Thanks, Dr. Amanuel. It was a very informative and comprehensive presentation. I was a little bit late to get in. In our clinic, we do give Paxlovid, but I didn't hear about it here because I came late. But my question is, the future direction of this vaccines and therapeutics. You said that the variant is the problem, not the ancestral viruses, and you try to compare it with the outside world where there is no access. And at the same time here also, now that COVID is here to stay, what should be the future direction, in your opinion, from all the information, experience that you've gathered? Thank you so much.
Thank you so much. So I think if I were to be asked, like Hamzi, what he says, if I were to be in charge of clinical trial design, regarding the future, the last question, I definitely would design a clinical trial that will assess what level of antibody titer is actually protective clinically. That's what the common thing that we don't know. And that's the reason we just keep giving booster and booster, but we're not dissecting all the factors that are contributing to that. Again, we may not have the data. I think it's going to be published sometime soon. I attended some expert meetings that discussed it, like non-published data. So the common theme is, yes, we know the immune strength wanes down throughout time, but when there is natural infection as going on as well, is that not significant enough to provoke it to generate new antibodies without predisposing you into severe disease state and actually updating your antibody titers to the circulating virus? The key is we are trying to prevent disease complication. So is whatever we have, the antibody titer from the first vaccine series, enough to protect us from disease complication? Or do we have to look for other options? And I tried to mention this one earlier. Some scientists with some level of data to back it, they think the lowering of the immune protection level is not the primary driver of the uptake of infections we're seeing. It's primarily driven by the new variants coming in. So immune system declining doesn't necessarily mean it's not effective. You might have some infection, but it doesn't progress into disease complication. And that's what we've seen. Even though infection rates are even severely underreported because of the home testing, but it's not translated into hospitalization and deaths. And that's what we are trying to target. The vaccines are targeting hospitalization and deaths, and it's not happening anyway. So we have to actually understand that part first. And if you can establish this level of antibody titer is protective enough, we do that always with hepatitis B. We test antibody titer. If they are less than 10, we give them another vaccine series. If there are 10 and above, we tell them you don't need a vaccine. So that's where we should be at this point. If I have to predict the future and how we want to predict the future. But with the current status, I think the future probably will look like more of once a year vaccine, because like you rightfully said, COVID probably is here to stay. But that probably will have some level of untoward effect, because all these vaccines, even though we always believe in them and say they are relatively safe or comparatively safe, they're not safe for everybody. We discussed about the pericarditis and myocarditis, and there is always, not always, but some data actually, they look into the people who actually had the pericarditis or myocarditis, and the troponin level on these patients has persistently increased even after that infection. So as you all know, troponin is one of the markers for heart complications. And if they are sustaining this high level of troponin level for a long period of time, and you keep give them the same vaccine, even though their initial reaction was minor, you're adding up on all this. And at one point, it will become significant. So continuously giving the booster without having the fundamental understanding how it's affecting us is probably not, I personally, don't quote me on this one, it doesn't reflect my institution's idea. It's just personal belief. I think that's one of the questions. The second question was what? Sorry, I forgot about it.
It was that question actually. It was just
Paxlovid,
more. Oh, Paxlovid, yeah.
Yeah, so Paxlovid, I think we discussed it at one point. Probably you joined us a little later. So we briefly discussed about Paxlovid and the precautions that we needed to do. More so, I briefly discussed about the clinical data that led into approval. Okay, this one. The key point that I tried to mention here is Paxlovid is, yes, protective, but the clinical effect was more observed in patients who was elderly patient and patient with high chance of disease complication with comorbidities. For young age with no disease comorbidities, there wasn't significant effect seen, and that is why the indication was limited for someone who has some level of predisposing comorbidity or any chance for the high risk of death or hospitalization. And we also discussed about the wide range of drug-drug interaction and precautions that we needed to make to treat our patients.
Okay,
Thank you. Thank you.
Yeah, thank you so much. It's almost time. Thank you again, Dr. Kehasse. This was really excellent and insightful presentation. I'm sure everyone got a lot of great updates, and specifically not practicing in clinical settings. This would definitely help a lot of us. Thank you. If there are any other questions, or if you want to give the last word, I would give it back to you, Dr. Amanuel.
Oh, I think I am immensely grateful for everyone taking their time to attend this one, because and more so for the discussion. I really wanted this to be not a lecture, because I may have some level of experience, but not an expert at all. And I would appreciate if you guys have perceived something that's not probably accurate, or maybe something that you didn't agree with this one. I would always appreciate your feedbacks. Always, we will grow together if we support each other, not only to boost our egos, but challenge ourselves as well. I am all for it, and I'm looking forward for more of this discussion in this platform. Aripco is doing an amazing job in creating these opportunities. So thank you, and thank you, and thank you, everyone.
Thank you, everyone. Enjoy the rest of your weekend.
Thank you all. Have a good day.